would just like to welcome everybody to our very special Let's Talk Period event tonight. Let's Talk AMH and Fertility. So my name's Isabella. I'm the founder of Let's Talk Period. And if you're new around here, we're a podcast and community that is all about all things endo, adeno, PCOS, and everything in between. Basically, your pelvic health go-to. And we are really lucky to be joined by two powerhouses tonight to talk all about AMH and fertility and what it means when we are living with conditions like endo, adeno, and PCOS to sort of be in a more proactive approach rather than, I guess, a freak out mindset where we can end up in that sort of panic or fight or flight. So just to have more information and be more empowered. So I would just like to do a little bit of housekeeping before we dive in. So if you could keep your cameras off and your microphones off, that will just help us with the sound side of things. And then if you do have a question throughout, if you could pop it in the chat, or if you don't want everyone to see the question, you can also toggle it to change the everyone to just me. And I would just get that question from you there. The questions that we do get, we will cover at the end of the session. So if you do think of something, you can either pop it in the chat or wait until we ask for questions, and then you can pop it in the chat, or you can pop your camera on and ask it yourself. It's so up to you. And then if something does come up and you think later that you have a question that you might want to ask, we can try and organise getting that answered by Maz or Rach later as well. But without further ado, I'd just really like to welcome Dr. Rachael Rodgers. She's an Australian trained gynaecologist with a subspecialty qualifications in reproductive endocrinology and fertility. She is dedicated to empowering her patients to make informed decisions through providing education and making sure her patients fully understand their fertility options. She boasts a very impressive academic background, holding bachelor degrees in a Bachelor of Arts, Bachelor of Science in Biochemistry, Immunology, in addition to her Bachelor of Medicine and Bachelor of Surgery with an honours as well. She's also got a Master of Science in Medicine, specialising in reproductive health and human genetics. She's also certified as a fellow of the Royal Australian and New Zealand College of Obstetricians and Gynaecologists. And in addition to that, as well as possessing a certificate of reproductive endocrinology and infertility. So very excited and honoured to have Rach here to be answering all our questions this evening. And then we are also joined by Maz Coote, who is the founder and CEO of WHEN Fertility. And Maz has got an impressive career in PR. And after about 5 years focusing on building that empire and PR agency, fertility wasn't something she was really considering. And she went to her GP to ask for an AMH test, and the results were a shock. And that sort of led her on a journey to undergo egg freezing and then really consider her fertility, because it was sort of I guess Maz can talk to this more than what I can during her bio, but it was a tough process for her, both physically, emotionally, and mentally. And I guess the importance of taking action. So I guess that experience had a lot of questions come up for her and thinking about what she could do. And so she will obviously touch more on her experiences and all about when we get to it. But without further ado, I would love to sort of just ask both of you ladies, if you could just share, to begin with, your go-to tip to manage your pelvic health. We might start with Rach, if there's something that you could share with our community about something that you might have as a go-to.
Oh, very big question. Hi, everyone. Thank you for the lovely introduction. You made me sound like quite the nerd, but I guess that is probably fitting. So I guess there's a couple of things. It's great that everyone is being proactive about their fertility, and we'll talk a bit more about that. I think one thing that is really important is that if you're worried about someone, if you're worried about something to do with your fertility or health generally, then you should be seeing a doctor about it. It's we don't sit here in this high tower saying, well, that was a stupid question, that was a stupid consultation. We're really keen to hear any problems that anyone's having, and help people overcome any issues that they've got. So the first stop is usually a GP, and if you find that you meet the doctor that isn't right for you, if someone's dismissive of your concerns, you should be seeing another doctor. So things like irregular periods, really severe period pain, family histories, so a mother having early menopause, you having any significant medical conditions, you should be seeing a doctor, and make sure you see the right doctor that takes those concerns seriously. So just having the confidence to get the treatment that you need. I hate it when I see people that have been suffering with, severe period pain or have been dismissed for some reason when they've got really valid concerns, because usually we can help people if we know about a problem. The other thing with fertility is that to understand that our bodies are built to have babies in the 20s. That's when egg numbers are high, that's when egg quality is really good. Now, that's incompatible with modern day life. I mean, we all want a degree of financial security. We want to settle down with the right person, not just anyone for the sake of having babies. So, on one hand, our bodies are saying, make lots of babies when you're in your early 20s, and society is saying, get your act together in all these other ways before you have babies. So just by doing things like an AMH test to work out where you are as far as egg numbers is a really big step in the right direction. Now, most women that are relatively young are going to have a good ovarian reserve and can be reassured from those tests. But occasionally I see younger women with really low egg numbers. And if I can pick someone up with a lower egg count before that becomes zero, I can help them. If someone's got a zero egg count, then there's nothing I can do as far as helping them have a baby using their own eggs. Certainly with donor eggs I can, but just taking that step, as Maz did with her fertility journey, because sometimes we do get surprises in it, and we can get a good outcome if we just know about it sooner enough. So don't let anyone dismiss either any symptoms that are worrying you or the fact that you're young, and don't settle for, you're young, you shouldn't need an AMH test, because most time young women are going to have a great result, but not always. And the point of doing it is to pick up those ones that are not great. It's a bit like, doing a pap smear. Like, why do we do pap smears? Well, the vast majority of pap smears are normal, but we do them to pick up the women that don't have a normal result. And it's similar for this with younger women, in that the vast majority are going to be normal, but we're really doing it to pick up the women that have actually got a low ovarian reserve and we need to do something about.
Thanks, Rach. Maz, I'd love to hear what your go-to tip is as well. Oh, you're muted still, Maz, sorry.
I'm muted for sound quality. Hi, everyone. I said it's just really great to be here. We're delighted to get to meet you and chat AMH. So thanks for having us, Isabella. Not surprisingly, given I've now worked with Rach building WHEN for a couple of years, I really do agree with her tips, and that's certainly a lot of what I've learned from her about being proactive, which I wasn't. I think that GP piece and kind of knowing your body and what feels right, what feels wrong, and having a feel for that, and then seeing a healthcare professional is really, really important. I'd say in my journey, I kind of did take those steps with a GP originally, but I didn't have a GP that was really, really strong in reproductive health and fertility. So for me, I kind of fell over there. So if I was to go back in time, I'd try and find myself a GP that was strong in those areas and could really help me with what I was talking to them about, which at the time was low AMH, which I didn't understand what that meant, and actually didn't until I got to Dr. Rodgers' office. So for everyone here, Dr. Rodgers was my fertility specialist on my journey. That's how we originally met. And then I think further to that is just being educated and getting yourself educated around what these numbers, what these tests mean, and these different parts of your fertility journey, so that when you are sitting with a GP or, you know, a specialist, you're a little bit more tooled up. You kind of understand what's going on and can have a conversation and advocate for yourself. And I wasn't. When I was sitting in my GP's office, I didn't know what AMH meant. I certainly didn't know what low AMH meant, and I couldn't advocate for myself. And that's kind of where my journey got really, really tricky.
I think both of your tips combined are so strong and such important takeaways already. Something we see often in the community is, I guess, that ability to advocate for yourself and keep going. And like what you were saying, Rach, about if someone's not listening to you, going to see somebody else. And also what you're saying, Maz, about being equipped with that knowledge, because it is so empowering. So I think they're both two really important tips to take away already. I'm just wondering, Rach, if we could actually dive into what AMH actually is, because we're using, I guess, the acronym quite a lot, and what it actually tells us about our fertility. I think we obviously associate it with our egg count, but what's it actually telling us?
Yeah. So really good question. So AMH stands for Anti-Müllerian Hormone. And the way it works is to sort of take a step back from that, is that women are born with all the eggs that they'll ever have. So at birth, women have about 1 million eggs, and those eggs progressively decrease throughout life until usually about the age of 50, when women run out of eggs and become menopausal. Now, eggs are so small that we can only see them with a microscope. So we can't give you an actual egg count. Even though we talk about doing an egg count, we can't give you an actual egg count because we can't see them. Now, but we know that the more eggs you have, the more follicles will develop on the ovaries at the start of each menstrual cycle. All a follicle is a little tiny fluid-filled cyst, just a few millimeters in size, containing an egg. So by doing an ultrasound and counting the number of follicles on the ovaries, we get an idea of the number of eggs. The more eggs, the more follicles. So by getting a follicle count, we get an idea. Ultrasounds are fairly expensive and invasive, but we know that those little follicles secrete AMH, or anti-Müllerian hormone. So by doing a blood test for AMH, we get an idea of the number of follicles and therefore the number of eggs. So that's how we get a good estimate of whether someone has got a high number of eggs, a normal number of eggs, or a low number of eggs. Now, AMH will only tell us about the number of eggs. It doesn't tell us anything about the quality of eggs. Now, I've had patients that, one who comes to mind, she was in her 20s and she had an incredibly low AMH result. But we picked that up, and she really wanted children in her life. She was in a great position in that she was married and was amenable to having kids a little bit earlier than she initially planned. So I just said, go and try and conceive naturally. She had a regular monthly menstrual cycle, and because she was young, her egg quality was great, bang, she was pregnant. So she got a baby. She actually managed to sneak in 2 and now completely menopausal, even though she's really early 30s. So egg quality and egg quantity are 2 completely separate concepts. Egg quality is really related to age. So you can get someone who is in their 20s with low egg numbers, but they can have great egg quality because they're in their 20s. Conversely, you can get someone in their 40s that can have reasonable egg numbers, but the egg quality will be really low. So egg quality is really, really closely associated with age, and that's pretty much regardless of lifestyle. So just because you're fit and healthy and go to the gym and drink all of those green drinks and do all the things you're supposed to do, it doesn't mean that you're going to easily have babies in your 40s, because your egg quality will be low. So AMH is just about egg numbers. And the big benefit by doing the AMH is if we can pick up a problem when you've still got eggs, then we can do something about it for you and help you have the babies that you want in the future. And if we pick up a really low AMH and we get eggs in the freezer for you, then you might go and live life and come back in 5 or 10 years when you're ready to have a baby. Even if you're menopausal, worst case scenario, by that stage, we can still get you pregnant using those frozen eggs. So that's the real value of AMH.
Okay, thank you. I think it's a really good thing to explain, especially around the quality side of things as well, because I think there's often misconceptions about what the test can actually tell us. And I think, yeah, it's important to determine that it's just giving us that count. Maz, I'd like to throw to you now to sort of dive a bit deeper about your own personal experience. So I'd love if you could share with everybody here about what it was like in that moment to be told that your AMH was significantly lower for your age than what is expected. And I know you sort of alluded to the fact that it hadn't really been something you were sort of considering, but what was that like, and sort of what steps were offered to you from there?
Yeah, well, I guess to really understand that moment when I am sitting in, my GP's office and told I have a very low AMH and that I'm not going to be able to have a family, or it's going to be very hard for me to have a family, you kind of have to go back in time, because I was in my late 20s and it was actually my mum that suggested I go and get an AMH test. I was kind of single at the time, working a lot. I was building my PR agency that you mentioned, and I certainly wasn't thinking about family planning or my fertility or reproductive health. And I had a pretty regular cycle. I'd never had any kind of concerns, I guess, from a reproductive health perspective, so it wasn't really on my radar. And I went down to my GP's office at the time. I did twist their arm for the test, so I'm kind of, I'd be closer to 30, probably about 30 at this point. And I get the test, it comes back and they tell me it's in range. So great, I take that, I put it in my back pocket and I go on my way. And I don't understand what AMH means. I certainly don't understand that it's continuing to drop. I don't understand really the concept of egg count. I kind of just go, yep, I'm in range, and I go on my way. And the reality was it was in range, but very much on the cusp. And so a couple of years later, I've met my now husband, who's also my co-founder in WHEN, and we start talking about having a family. And I think, oh, okay, well, I'll go and, start exploring my fertility again. And so the first stop is, an AMH test. I have another egg count test. And when it comes back, it's really dropped. It's halved. My AMH is halved, and it's now considered very low. And my GP at the time, who's a new GP, not the original GP, tells me that what that means is I'm going to find it very hard to have a family. And so, again, not really being educated or understanding what AMH means, I accept that, and I think, oh, okay, it's going to be challenging to have a family. So that's the moment you've asked me about, I guess, Isabella, and it was pretty heartbreaking. It was kind of it was a shock, and it was really, really tough. And I actually went home and told Brett that I knew having a family was important to him. And I came home and I said, I don't think we're going to be able to have a family. I don't think that's something that we're going to be able to have a family. And so he says, well, let's just do the research. Let's just understand this more. So we dive into journal articles and you name it. We're trying to read everything. And we come across from another specialist, actually, who's retired and had written a journal article, Dr. Rachael Rodgers. And he says she is amazing. She is the best at what she does. She's fantastic with low AMH, but she's also a really wonderful person. You're going to like her. She's who you have to see. So I decide I have to see Dr. Rachael Rodgers, and I call her office. She's very busy. She's booked out for months and months. And I beg and I cry for my appointment, and her very, very kind receptionist books me in, I think within kind of a 2-month period. So fairly quickly, given the wait list. And when I get into Rachel's office, Dr. Rodgers' office, and she's sitting there, she says, low AMH doesn't mean that you're not going to be able to have a family. It means other things. We need to think about, your family planning. What are your goals? What do you want? And let's see what we can do. It doesn't mean you can't have a family, but, you need to be proactive about this, because as Rachel's pointed out, I'm probably a little bit like that patient she has that was able to conceive. I do have a daughter, but my AMH continued to decline like this and is now very, very low. So I guess that's kind of a long version. Was it a long version of my story?
No, I think that's fine. And I think a lot of people can probably resonate with that. I guess when you're told something and you might not necessarily have heard much about it, and you sort of do go into that fight or flight response of that panic, like I'm not going to be able to have sort of what I envisioned or what we envisioned, and then diving into that research mode of, well, what can I do? And going down all the rabbit holes. So I think it brings a lot of comfort that I guess people aren't alone in that. I would love to know a little bit more about when and how that sort of came about from your experience.
Yeah, well, I guess what happened next in my journey. So Dr. Rodgers explains to me a little bit like the 101 we've just done tonight, what egg count is and what it means. And I go, oh, okay, I understand. And then she kind of makes a plan. So I tell her that I would like children, and maybe 2. And so she makes a plan, and that plan is we're going to go and freeze my eggs. So we're going to go and preserve my fertility, because at this point I'm 33 and my AMH is 3 point something, so it's very low. And so we decide to freeze my eggs. That process wasn't, incredibly straightforward for me, given my AMH was quite low at this point. And I think where I found it really challenging is when I'd got that first AMH test in my late 20s. If I'd met Dr. Rodgers then, we would have frozen my eggs, and egg freezing could have looked different for me. And I think because it was these years later, there was this big gap between having been able to do something, like I took the right step, but didn't have the right support around it, and therefore didn't do anything when I could have. And I think that was probably one of the most frustrating parts of my journey. So we went and froze my eggs, but it was, 3 rounds and, a longer journey to get that target number of eggs that Dr. Rodgers wanted to store, so for the likely success of a future pregnancy. So yeah, 3 rounds back to back of egg freezing. And I got to the end of that and went, well, if I'd had this information sooner, if I'd met Dr. Rodgers sooner, had access to her, the education and the support, my journey could have looked super, super different. So that's when we set out to build WHEN. And it is the testing right through to the support, the care, and the reports that's going to help you make good decisions with that proactive information. So I think for us, it's really about moving the fertility conversation forward wherever you are and making it a proactive one, rather than one where, okay, you've found a problem and then now we're going to go and address it. So by moving it forward, I think we really exist to give people more options to help them achieve those kind of future family planning goals.
And I think it's so important to have that proactive response rather than that reactive one. And something that I personally can relate to with being told, oh, we'll cross that bridge when we come to it, we'll cross that bridge when we come to it. And then you get there and the bridge is a bit rocky and wonky and it's a bit sway and it's, again, not as straightforward or streamlined as what it could have been if we did have that information a little bit sooner. So no, I really am grateful for what you're doing in that space, Maz.
Oh, thanks, Isabel. And I think as well for me, and Dr. Rach can go into more detail and obviously the medicine behind it. But for me, that low AMH was without symptoms, without an egg count test, without being proactive. I wouldn't have known. There were no related symptoms. And I think that was also a part of it that was challenging, because I looked at it and went, wow, there must be women just like me, just traveling through life.
Yeah.
And not knowing.
Absolutely. Rach, can you speak to that any more around, I guess, asking for that AMH test, even if it's not something you've really thought of, or I guess you don't really have those symptoms of like, oh, my egg count's dropping, your body's not really, I guess, telling you that. Is there anything that you have to sort of offer around that?
Yeah, look, if someone has got a high, usually high, normal or low ovarian reserve, they often have a regular monthly menstrual cycle. So occasionally women with a high ovarian reserve, if they've got PCOS, it's an irregular cycle. But normal or low, as long as it's not critically low, they'll have a normal monthly menstrual cycle. So if your AMH was, say, 20, or if it was 2, you're not going to be able to pick that up from a normal monthly menstrual cycle, because the ovaries will secrete the right hormones until they sort of fall over and stop working. So you don't get that warning. So yeah, absolutely. You can't tell just because you're healthy, just because you've got a regular menstrual cycle, doesn't mean that your AMH and your egg count is okay.
Yeah, so I guess it is important to, I guess, have that information and ask for that test and get, yeah, I guess, arm yourself with that knowledge.
Yep, absolutely.
I would love to know about the role in which hormonal contraceptives play in affecting our AMH results. A lot of us are on different hormonal contraceptives, whether that's oral or devices and things like that. What should we consider when we're looking into testing our AMH while using them, and do they have any impact?
Yeah, so really good question, also really tricky question. Certainly the hormonal contraceptives do have the capacity to suppress the AMH result. So the classic one is the oral contraceptive pill. And the general teaching is that it might reduce your AMH by about a third. So if, for example, you were not on the oral contraceptive and your AMH was 12, if you were on it, your AMH might come back at 8, something like that. Now, that is a great general rule, but it's like saying how tall is someone. So if you go, oh, the average height is 165 centimeters, it doesn't tell me about you, just tells me that's the average height. So whilst the reduction is on average about a third, what I see in clinical practice is some people aren't too suppressed by the pill, and some people are massively suppressed by the pill. So it's not like we can just get a number, add a bit, and then give you your true result. It's not as simple as that. We just know that the hormonal contraceptives suppress it. Now, by far, the oral contraceptive pill suppresses it the most. Things like the Mirena IUD, they have very, very, very low doses of hormones associated with them, so they don't have too much of an impact. But you can test your AMH while you're taking a hormonal contraceptive, because let's face it, people aren't just taking it for the hell of it. They're taking it for a reason. So whether that's contraceptive or whether it's related to periods or what it is, you can do an AMH test while using the hormonal contraceptive. But if it's low, don't freak out and necessarily think that that is exactly what it is. You need specialist advice in that regard. Some people might be in the position where they're thinking of ceasing the pill anyway, and so they might stop it and then do another AMH test 3 or so months later and get a more accurate result. Other people might say, well, look, it's not critically low now, say you're 20 and your AMH is 8. One thing that a lot of people opt to do is just repeat it in 6 months and see if it's fairly stable. So there's a few ways of kind of getting around it, but yes, hormonal contraceptive, they do suppress AMH.
Thanks for that, Rach. I think that's important, and I guess something that shouldn't, I guess, deter you from getting that AMH checked. Just something to, I guess, be aware of and consider. And then depending on those results, having a conversation with your specialist about what it means for you personally and sort of what the next step would be depending on those results.
Yep, absolutely.
Yeah. Something that you did just touch on before is around PCOS and having those higher levels. What can that mean for their fertility in regards to AMH and I guess the role that can play having that high ovarian reserve?
Yeah, I see a lot of people with PCOS that are worried about their fertility, and as a general rule, I'm not. There's a lot of bad press about PCOS causing fertility problems. Women with PCOS have a lot of follicles. It really should be called polyfollicular ovarian syndrome rather than polycystic, because cystic sounds like it's pathological. It means that they've got lots of eggs, lots of follicles, and have a high AMH. So would I prefer high egg numbers to low egg numbers? Absolutely. Let's go for the high egg numbers. But the reason that a lot of women with PCOS have trouble conceiving naturally is, well, their hormones get a little bit out of sync and they don't get a regular monthly menstrual cycle. And if someone's not having a regular monthly menstrual cycle, they're not ovulating each month. If you don't release an egg, there's nothing to fertilize. So therefore, getting pregnant naturally without any sort of assistance can be quite challenging. PCOS is usually one of the easier problems to overcome. We've got medications. It might just simply be 5 days of taking a pill and then us monitoring your cycle that might be enough to make someone ovulate with PCOS. But generally high numbers, late menopause, fabulous. But don't get tricked into thinking just because you've got a high egg count that it means that you can delay fertility, because egg quality will decrease just like it does for someone with a low egg count. So high egg numbers in your 40s is a little bit helpful, but not very helpful because of the egg quality.
Yeah, no, thank you for that. I think, yeah, it's just important because I think something that's, again, like I guess a misconception as well. So good to, I guess, have in the back of your mind. And I think especially when people are living with a combination of the conditions as well, they might have PCOS and endometriosis. So just, I guess, all of the things playing off each other. But I think, again, like what you said, the quality over the quantity. So you could have PCOS and have a high number and then be in your 40s, but still that quality has reduced. So yeah, I guess, again, that proactive piece is so important. I guess leading into endometriosis, there's an increasing body of evidence forming around the relationship between endo and adeno specifically as well, and having lower AMH levels. But obviously, with respect to endo and adeno, the research around that is still yet to be fully formed, and we need more definitive links there. But what are some of the reasons what are some of the reasons that our AMH can be affected or be on the lower side if we are living with these conditions like endo and adeno?
Yeah, so I guess there's different degrees of endometriosis. There's, in the case of severe endometriosis, women can get these big blood-filled cysts on their ovaries called endometriomas, and they certainly damage the ovaries. Taking out an endometrioma, so surgically excising it, inevitably does some damage to the ovary. So that's a really clear-cut relationship, in that women with these endometriomas, particularly if they've been resected and grown back, they can have a really low ovarian reserve. So it's really problematic in that regard. Mild endometriosis that doesn't affect the ovaries is much less of a problem as far as ovarian reserve is concerned. It's very difficult to do studies about women with mild endometriosis, comparing them to women that don't have mild endometriosis. Because mild endometriosis we can't see on an ultrasound. So if we had two women, one with no endometriosis and one with mild endometriosis, you can't pick it on ultrasound. The only way you can tell is by doing diagnostic surgery and physically having a look in their pelvis. Now, we don't want to do more surgery than we have to do. Obviously, it's not fun, and there's a risk of complications there. So it's not like we can take 100 women, have a look at their AMH, and then operate on a lot of them, symptoms, no symptoms, to get that result. So for those kind of limitations, we don't have great data. But if someone has got fairly significant period pain, then there's a good chance they've got endometriosis. And the degree of endometriosis doesn't necessarily correlate with the amount of pain that they're getting. So you can have someone with what's classified as mild endometriosis with really nasty periods. What's normal in a period? Most people get some degree of period pain. They're a bit grumpy at the time of their period. They take some Panadol occasionally. They're not, they don't feel like going for a run, something like that. That's really normal. Some women sleep with naprogesic by their bed, because if they wake up in the middle of the night when their period's due with the slightest twinge, they'll immediately reach for it and take it because they're scared of getting terrible period pain. That's not normal. Some women can't go to work. They've got such bad period pain. Some people are regularly taking Nurofen, Panadol, using hot packs. That's not normal. Some people, I've had stories about women that when they go to open their bowels when they've got their period, they'll just sit on the toilet and cry because it's so bad. That's not normal. They've almost always got endometriosis in that regard, but it's not enough to diagnose it for the purposes of a research study. Now, the other thing to know about endometriosis is that, yes, it does reduce your ability to conceive naturally. And someone with symptoms of endometriosis, and so suspected endometriosis, is more likely to need IVF in order to conceive. This is where it gets tricky, in that if someone has a low AMH, a low egg count, we get less eggs in a cycle of IVF, and therefore the likelihood of success in that cycle is lower. So you end up, someone's got a low ovarian reserve, we tend to do more cycles to get them the baby that they want. So what the flip side is that if someone has got symptoms of endometriosis, it's even more important to do an AMH and see what that is, and consider maybe egg freezing or embryo freezing if they're not in a position to have babies soon, because the younger they are when they do their egg or embryo freezing or their IVF, the better quality the eggs, the more eggs we'll get, and the better success rate is going to be.
All right, thank you for explaining that, because again, that's, I guess, one of the reasons why we're having tonight's session, but also something that is so often spoken about within the Let's Talk Period community as well. So I think it's really important to cover for sure. I would love to know if there's any ways that we can work towards optimizing our fertility and being proactive when we are living with these conditions. I know you said going to the gym and being healthy can't fix everything, but is there anything that we can implement if we are, I guess, in our 20s and 30s or even late teens to help us have the best chances with our fertility?
Yeah. Yes, so being proactive is really important. And whilst there's nothing there's no magic pill, there's no magic trick that can make your egg numbers go up or that can improve your egg quality. There's a whole lot of things on the internet that are usually very expensive supplements that will claim that they'll do all of these sorts of things. You can buy tea that apparently makes your egg quality and quantity just go through the roof. It's not true. You can avoid the bad things in life. So smokers, we know that damages eggs, and smokers actually have an earlier menopause than non-smokers. So avoiding smoking. Vaping is probably in the category of smoking, but the issue we have with vaping is that there's different vapes and they've got all sorts of chemicals in them. Different vapes have got different chemicals in them and they can be potentially harmful. So no smoking, no vaping. They are probably the two biggest ones. Being generally healthy is good. Trying to, not only for fertility, but for general health. So trying to get most of your nutrition from fresh fruit and veggies, that's really important. Minimizing processed foods, also minimizing plastics. Now, we don't know exactly what's in plastic, and probably different plastics have got different things, and it's not necessarily good stuff in plastics. So just simple things that are really easy to do. We can't kick plastics out of our life completely. I tried to do it one stage and I failed dismally. But things like if you get takeaway and it comes in a plastic container, don't reheat it in that plastic container in the microwave. Put it in a non-plastic container and reheat it. Store food in non-plastic containers. Just because we don't really know what's in the plastics, and probably different plastics have got different things. So just trying to minimize that unknown that you're putting into the body. So they're the biggest things really. And then again, being proactive, thinking about not just the first baby that you want to have, but the last baby. Because if you've got someone at 35 that just wants to have one child, that's pretty achievable. But if you've got someone at 35 that wants to have half a dozen children, that's not really achievable if we don't take proactive steps. So not just thinking about baby number one, when will I start trying to have a baby? Think about when am I going to be having my last baby, and taking that into consideration. And if you've got a fertility problem or anything that can potentially affect your fertility, see a fertility specialist. So if you've got endometriosis, come and talk to a fertility specialist about what should I do to optimize my chance of having the babies that I want in the future.
Yeah, no, thank you, Rach. I really appreciate that answer. Maz, I'd love to know, what would you like to see change within this space?
Yeah. Look, I think one thing I learned in my journey, and then also in working on WHEN and taking WHEN to market, is that we have this very narrow definition of fertility. And I think when you say the word fertility, people think, or a lot of people think, well, that means I want a baby now. You know, fertility relates to conceiving now. And I think it's such a narrow definition. It's a definition that leaves people behind, and certainly left me behind. And I think what we're trying to do is really move that conversation forward. You know, fertility is a journey you start when you're ready to start it, and can involve things like looking at your AMH and family planning with or without partner. And I think that's really our goal, is to move that conversation forward and really help widen that definition of fertility, so we aren't leaving people behind.
Yeah, I think that's so important. Rach, I'd love to know what you would like to see change as well.
I would like to see women being more educated, and this is a big step. We've certainly done a whole lot of educational videos. Now, in school, everyone gets taught how not to have a baby. No one gets taught how to have a baby. And that's really important to bring that level of education into play. So that's one thing to think about having a baby, that education. I'd like to see everyone getting their AMH tested in their 20s. Now, not everyone on the planet's going to agree with me about that, because so many people are going to have a normal AMH, but I'm interested in picking up those women that don't have a normal AMH early while I can still help them. I would love to see, I would love to see more government support of things like egg freezing. Embryo freezing, because it makes a lot of sense to me that if I think someone's going to have a problem down the track with their fertility, it's better that I freeze eggs or embryos for them when they're young, rather than going, no, let's wait until you're trying to have a baby, which might be in 5 or 10 years and might be at a stage where, for example, endometriosis might have destroyed their ovaries, or anything like that. I'd like to see it happening earlier, because my aim is to do as little as possible for my patients. I know that sounds silly. I'd really do anything for them, but I don't want to have to I would rather do one IVF cycle for someone that's young than do half a dozen when they're older. So I think it's actually a cost-effective thing for the government, for women, for to be doing when they're younger rather than they're older. And I'd like to see a lot. We all talk about social egg freezing, and that's egg freezing for no medical indication. And we talk about it like there's no medical reason to do that, therefore there's no Medicare benefit. Well, isn't there a medical indication? Because, you know, egg numbers go down, egg quality goes down. So isn't it a very proactive thing? So I'd like to see more support for, and education for women to be more proactive in what they want as far as fertility is concerned.
Absolutely. I could not agree more. And I think also something I'd like to see change as well, if I put my 2 cents in, I'd like to see the blood test itself be bulk billed, because that's often something that is a cost associated with it, and something that I guess that was listed to me as a deterrent as to why I shouldn't do it, because I'll have to pay for the blood test. So yes, I think more support around testing, having that education piece, and being proactive in so many ways. I think that's so great from both of you. Thank you so much. I would love to dive into some questions that we've had come through now, if that's okay. I'd just like to remind everybody that the questions that are asked are sort of general advice, and if you are wanting personalized advice to your scenario or situation, then it's best to book a consult with your healthcare professional or book in with a fertility specialist, because they can actually then give you a comprehensive answer that's directed to you especially. So I guess the information that Rachael is providing, and Maz we're provided as well, is sort of generalized in nature and isn't specific to your situation. If you do have any questions, feel free to pop them in the chat now. I have had a few come through already, so I'll get to those first. And then, yeah, if you do have anything, just pop them in the chat and we will ask them. So the first one we've got through is, have you helped couples that have fertility problems on both sides in a male and female couple where they've got, I guess, that dual factor fertility?
Yes.
Or infertility, sorry.
Many times. Yeah, absolutely. Absolutely. Just because one person has a problem doesn't mean they're automatically going to find a partner that doesn't have a problem. So yes, absolutely.
And I think that's something that's often not considered as well. We get a lot of onus put onto the female when we are in that heterosexual relationship, and the male isn't considered until, I guess, you do get to that fertility specialist's office and you go, hey, actually, there might be something with you as well. Let's explore that too, or let's just cover all our bases. The next question we have is, does AMH drop at a consistent level each year, or is it, can it drop significantly? And does AMH drop differently for each person?
Oh, really good but tricky questions. There's a lot of things that the textbook says, but women don't necessarily do. So I guess the classic one is the menstrual cycle. The textbook says that women should have a 28-day menstrual cycle and should ovulate on day 14. Most people, it's kind of pretty true, but no one really has exactly 28 days. Might be 28 to 30 days, that kind of thing. AMH is similar. So you would expect a fairly steady decrease throughout life, but that isn't guaranteed to happen. Sometimes there can be life events that can cause a big crash in AMH. Chemotherapy, so if someone gets cancer and has chemotherapy, that causes a big crash. If they have surgery to their ovaries, that causes a big crash. They're things that you can take into consideration, but have I seen AMH go from fairly high to quite low in a relatively short amount of time? Yes. The general rule is that it comes down gradually, but occasionally we do see it just drop down quite substantially for no reason that we can pinpoint.
Thank you. And then I guess it leads back into that importance that we are checking it, I guess, sooner than later, so we are informed and can check in with it more regularly.
Yeah.
Yeah.
And it's that tracking piece, I think.
Yes.
Rach, isn't it? I had that first AMH test, but didn't look at it again for some years. And I think if I'd been looking at it, given how it was low at that first test, or on the cusp of low, it was in range low, I probably should have looked at it annually, or, Dr. Rodgers would have a recommendation there. But it certainly wasn't to forget about it for, a few years.
Yeah, I think that's one of the problems, is that there is a wide normal range of AMH. So if someone sneaks into the normal range, if it's right down the bottom of that normal range, then yeah, it's written in black on the report form and it says normal. And a lot of people that aren't doing fertility all day, every day will go, well, you're in the normal range, it's fine. But it's got to give you a bit of a heads up that, hang on, this is at the really low end of the normal range. Maybe it's not exactly fine. And GPs, I sometimes joke and say, I couldn't be a GP because it's way too difficult. You're supposed to know everything about everything. And I still maintain that. I think that being a specialist, one of the great things is that I'm expected to know everything about this tiny little area of medicine, and I'm quite comfortable with that. I'm not expected to know about, sprained ankles and heart problems and arthritis and elderly people with dementia and all of these kind of things. So GPs, they're very, very good on the whole, but they can't know everything about everything. And if they see an AMH in the normal range, a lot of them are going to go, yep, it's normal, all good, just like they did with Maz. One thing, and I know I shouldn't be talking about products, is that Maz's AMH, when it comes out in the WHEN Fertility thing, it gives you an idea of where you're falling in that normal range. It's not just a number on a page, it gives you a little bit of a graph. And the idea of it is to give people a bit of a heads up. If you're tracking fairly low, like yes, you're in the normal range, but you're in danger of falling off the edge. So, and there is a lot of work that has been done about explaining what AMH is and how to manage a low AMH. But the take-home message is if you're worried, then come and see a fertility specialist. And all we do all day, every day is deal with these kind of issues. So we're here. It's not a silly consultation. It's a proactive one that we're really supportive of.
Absolutely.
Rach, you can talk about the report part of WHEN. For everyone on the call, we work in a regulated space, so there's things we can and can't talk about. Our reports were built by Dr. Rodgers and Professor Ledger, and they have a graph that's a visual indication of your AMH and where you kind of live. You can download a sample report on our website. So if you scroll down to the bottom, you'll see me, hi, again, and you can download a sample report there and kind of have a look at how we present, as Rach said, that information. And it is a lot more than the result in the graph as well. It's, everything that Dr. Rodgers wanted you to know, getting that result if she could kind of be in the chair. And we've also produced videos to go with it as well. There's and I know your community actually, Isabella, are receiving the masterclass as a gift.
Yes.
It's a 30-minute session with Dr. Rodgers and Professor Ledger. Again, everything they kind of want you to know when you're being proactive on your fertility journey.
Yeah, so I think we should touch on that now. It's a really good point, and I'm sure Rach, you can talk to this as well. But yeah, if you are part of the Let's Talk Period community, you do get access to that for free as a gift, and I will attach the code for you to access the masterclass for free as well when I send the recording out too. But yeah, I'd love to sort of know around how you decided to develop the masterclass and I guess what was important to include as well, I guess, for both of you.
Well, I guess if I start it, Rach, the contents are certainly Dr. Rodgers. For us, what we understood is that in our journey, it wasn't until we got to Dr. Rodgers' office that we understood what AMH. I describe it as a big hug, and I think I burst into tears for the fourth time on that part of the journey. And I think what we understood is that not everyone can access a specialist, whether that might be location based, whether that might be cost prohibitive. And I think we wanted to make that starting conversation Dr. Rodgers was passionate about this, making it as widely available as possible there, and kind of helping people start that conversation in an informed way. So that was kind of the why. It really came from the big gap in our own journey, where as you know, we were deep in Dr. Google, which was not the right place. When we got to Dr. Rodgers' office and had our half-hour consult, that was the right place for me.
I think, yeah, I'd agree with all of that. So, I mean, it breaks my heart. I mean, sometimes I get women that walk into my office and I say hello, they sit down and they start crying. And the first time it happened, I was like, what have I done? What have I said? I've just said hello. But they've built up all of this anxiety. They've got this test result. And just like Maz, you get a low AMH, then they're told you'll never be able to have a baby. And they spend the next few days or weeks in tears before they land in my office. And they hold it together until they get in my office. And then all these tears are just everywhere. And it's heartbreaking to see, because it's not necessary. For most people, the vast majority of people with a low ovarian reserve, we can get them there. So, you know, as long as age is really prohibitive as far as equality is concerned, but if we're doing all the right things when women are younger, there's a really, really good chance that we can get them there with the outcome that they want. So it's just sad to see women being so upset about something that they don't need to be upset about. And that's why the educational component of WHEN was so important to me and Professor Ledger, in that we were like, well, no, women have to understand this. They need to understand their fertility. And to Maz and Brett's credit, they've been really receptive and keen to provide that information to patients the way that we thought was appropriate.
Yeah. And I think knowledge is power, and it makes you feel so much more confident when you do have that understanding and that knowledge, because then you do feel like you have more options and you're not acting from such, I guess, a scarcity mindset and that fear mindset. You're like, okay, well, I know this and these are my options. And it sort of gives you, I guess, that good starting point, having that educational piece behind you as well. Thank both of you for your time this evening. I'm really grateful for both of you speaking from your personal experience, Maz, and your professional experience, Rachael. And I think these conversations are so important for, I guess, moving us toward that more proactive approach and having that increased education around what it means and our options. So we are coming from that more informed and empowered position. So yeah, I just am very grateful for both of you. Thank you so much for this evening.
Oh, thank you for having us, and thank you for all you do with your community.
Thank you. And thank you so much to everybody else who joined this evening. If you haven't already, make sure you are following us on Instagram at Let's Talk AU, because that's how you find out about all new events. And then we also have our Let's Talk community on Facebook as well, which is where you can ask questions and just be around other people who get what you're going through. And we have a good time in there. You can share memes and have event and have some fun. So yeah, make sure you join that. You just search Let's Talk community on Facebook. But we'll close for tonight, and thank you so much, everybody.